Hi, I'm Dr. Hunter Best. I'm an assistant professor of pathology at the University of Utah School of Medicine and medical director of molecular genetics and genomics here at ARUP Laboratories. I will spend the next few minutes discussing the utility of genetic testing for mutations in the EIF2AK4 gene in the diagnosis of pulmonary capillary hemangiomatosis and pulmonary veno-occlusive disease. Pulmonary capillary hemangiomatosis, or PCH, is a rare disease characterized by the abnormal proliferation of capillaries in the lungs. These capillaries expand into the alveolar septa, bronchial walls, and pleura, and ultimately cause pulmonary hypertension. Pulmonary veno-occlusive disease, or PVOD, is also a rare cause of pulmonary hypertension. However, it is characterized by the widespread fibrous intimal proliferation of the septal veins and preseptal venules of the lung. Often, PCH is confused with PVOD. There is a large degree of overlap in the clinical presentation and histological changes observed in patients suffering from both of these disorders. In fact, it is estimated that 80% of patients with pulmonary capillary hemangiomatosis have venous changes similar to those observed in PVOD. Likewise, an estimated 70% of patients with pulmonary veno-occlusive disease show capillary proliferation similar to that observed in PCH. As you might imagine, this makes the pathological diagnosis of either of these disorders very difficult. Recently, mutations in the eukaryotic translation initiation factor 2-alpha kinase 4, or EIF2AK4 gene, were identified as the first known genetic cause of both PCH and PVOD. Traditionally, the diagnosis of these disorders has relied almost exclusively on the histological review of tissue obtained through a lung biopsy. However, lung biopsy is a risky procedure in patients with pulmonary hypertension. Therefore, this procedure is often not performed. As a result, many patients with either pulmonary capillary hemangiomatosis or pulmonary veno-occlusive disease are misdiagnosed. The most significant benefit to the discovery of EIF2AK4 gene mutations in PCH and PVOD is that now we can offer non-invasive genetic testing to confirm a diagnosis in patients suspected of having either of these disorders. Currently, testing for mutations in the EIF2AK4 gene is performed by DNA sequencing of the entire coding region of the gene. This test is relatively non-invasive as the sample required is a single tube of blood collected in a purple top EDTA tube. Mutations in the EIF2AK4 gene are inherited in an autosomal recessive manner. As such, the detection of two pathogenic EIF2AK4 gene mutations confirms the diagnosis of PCH or PVOD. The detection of a single EIF2AK4 mutation indicates that the patient is at least a carrier of PCH or PVOD and may be affected if a second mutation is present that is not detected by the testing methodology. If no EIF2AK4 gene mutations are detected, then it reduces the likelihood that a patient is affected with pulmonary capillary hemangiomatosis or pulmonary veno-occlusive disease, but does not exclude it. It's important to note that mutations in the EIF2AK4 gene do not account for all cases of PCH or PVOD. Based on the available literature, approximately 90% of patients with hereditary cases of these disorders and an unknown percentage of idiopathic cases will test positive by the EIF2AK4 full gene sequencing test. It is therefore possible that a patient that is clinically affected with pulmonary capillary hemangiomatosis or pulmonary veno-occlusive disease might still test negative for mutations in this gene. Additionally, patients with mutations in areas of the EIF2AK4 gene that are not tested, such as deep intronic or regulatory regions, or those with large deletions and duplications, will also not be detected by the current methodology. More information on genetic testing for mutations in the EIF2AK4 gene can be found on our website at www.aruplab.com.